Today, really more than ever, the cost of cancer care is very high. For many people, patients, it's unaffordable. So we need to be good stewards as physicians and practices of controlling the cost of cancer care. That doesn't mean that we pick only inexpensive treatment. It means that we're thoughtful about the decisions we make. What we do when we design clinical pathways is we focus on those regimens that are the most efficacious, but if they're equally effective, then we start focusing more on what's more cost effective. And so the pathways are designed to have lower cost, higher value choices. So if you are choosing treatments on pathway, by definition, you will be using more cost-effective regimens. And in the aggregate, as you do that over month after month in a practice, it stands to reason you're going to save money. The other thing that clinical pathways does is it typically addresses late-line therapy. There aren't usually substantial choices as people get more and more therapy because typically treatment doesn't work. So it's more of a sort of a questionable decision to go even further with chemotherapy. And clinical pathways typically doesn't allow that if the evidence doesn't support it. If you're not giving those extra drugs and you're not making people sicker, then chances are you're saving money as well. So there's a lot of inferences how it can save money. We've actually published some data to show that it can save money. Some of that was presented at this meeting. And so I think not only the evidence says that it saves money, but intuitively it makes sense that participating in pathways saves money, which is good for really all stakeholders, patients, payers, practices, et cetera.